Welcome to this presentation on vitamin D. This presentation aims to provide information on vitamin D and vitamin D supplements in the context of residential aged care facilities as part of the VITAL study. The VITAL study is focused on providing education and support to relevant stakeholders in residential aged care facilities to encourage the uptake of vitamin D supplements by residents for the prevention of falls. This study is funded as part of the Cognitive Decline Partnership Centre with researchers based at the University of Sydney. Before we get started, it is important that you have completed the pre-education questionnaire, as this will be repeated at the end of this module so that the researchers can understand the impact that this information has had on your understanding and knowledge of vitamin D. If you have not yet completed the questionnaire, please pause this presentation and click on the link provided to complete the questionnaire. The learning objectives of this presentation are to understand the function of vitamin D, to understand the causes and extent of vitamin D deficiency in Australia, to understand the effects of vitamin D deficiency and groups that are at risk, and to identify sources and understand recommended intakes of both calcium and vitamin D. What is vitamin D? Vitamin D was initially classed as a vitamin after its vital role in the absorption of calcium and development of bone was identified. Unlike other vitamins, however, it was later understood that vitamin D is primarily sourced from the sunlight and acts more like a hormone in the body. There are two types of vitamin D. Vitamin D2 is found in plant-based foods such as mushrooms and also some supplements, whereas vitamin D3 is the more readily available form from the sunlight's UVB rays, some foods, and also now the majority of available supplements. This diagram provides an overview of how vitamin D is produced and works in the body. Our main source of vitamin D is from sunlight, and more specifically, the exposure of our skin to UVB sunlight rays. We will discuss other sources of vitamin D later on in this module. UVB rays combine with cholesterol underneath the surface of our skin to produce vitamin D3. This is transported to our liver and converted into 25-hydroxy vitamin D3, which is the vitamin D molecule measured in a blood test. This form of vitamin D travels to the kidney, where it is activated to what we call 1,25-dehydroxy vitamin D3. This activated form of vitamin D acts to increase calcium absorption from food in our digestive system and helps with building stronger bones. We therefore know if individuals do not have adequate sunlight exposure, have problems with any of these organs, or do not consume adequate dietary calcium, their bones will likely be affected as this pathway will not operate effectively. Vitamin D functions. In addition to ensuring strong bones, vitamin D also works in other ways to improve our overall health. We know that vitamin D ensures calcium is absorbed and transferred to our bones. However, adequate vitamin D is also linked to improved muscle function. Having low vitamin D levels has been associated with decreased muscle strength and reduced balance, so ensuring adequate vitamin D levels can minimize this risk. Vitamin D also plays a role in maintaining our immune system, which is particularly important for our aged care residents to resist infection and illness. Causes of deficiency. There are a number of contributing factors to risk of vitamin D deficiency. The obvious factor would be if someone is not getting adequate sun exposure, as this is our primary source of vitamin D. This is of particular concern to many groups, including residents in aged care facilities and people who work indoors. Exposure to UVB rays can also be influenced by the time of year, as we know sunlight in the winter months has less UVB rays than the summer months. Our place of residence also dictates the availability of UVB rays, depending upon how far away from the equator we live. So for instance, the availability of UVB rays is higher in northern parts of Australia compared with southern states. People with darker skin require longer exposure times for UVB rays to produce adequate vitamin D, so this may also be a cause, and of course if we cover our skin up when we are outdoors, it is likely that we will not receive adequate sunlight. Other factors that may contribute to risk of vitamin D deficiency includes older age. As we age, our skin becomes thinner and has reduced cholesterol under the skin, which is required to produce vitamin D. It is also believed that genetic factors may be playing a role, however we do not know much about this at this point. If our body has altered storage of vitamin D, this may increase our risk of deficiency. For example, as vitamin D is a fat-soluble vitamin, people that carry excess body fat are likely to store vitamin D in these fat cells, and therefore will have less vitamin D circulating around the body to absorb calcium. Some medications or inadequate intakes of calcium may increase the rate at which our body breaks down vitamin D, leaving us with inadequate amounts. Now let's take a look at the extent of vitamin D deficiency in Australia. This graph shows results from the National Health Measures Survey in 2011 to 2012. As you can see by following the pink line, older adults were less likely than younger adults to be vitamin D deficient. But at the same time, by looking at the brown line, you can see that vitamin D supplements were more commonly used among older people. Vitamin D deficiency, as marked by the pink line, ranged from 31% of those aged 18 to 34 years down to 15% of those aged between 65 to 74, before increasing again to 20% of those aged 75 years and over. This Australian Health Survey did not include residents living in residential aged care facilities, so if we look specifically at this population group, other research has reported rates of vitamin D deficiency to be up to 75 to 80% of residents, as opposed to only 15 to 20% of older people living in the community. Children, on the other hand, had relatively low levels of vitamin D deficiency. Around 15% of children aged 12 to 17 years were deficient, with similar rates for both boys and girls. These two maps of Australia tell us about rates of vitamin D deficiency in different parts of the country at different times of the year. As you can see in the second map, rates of vitamin D deficiency in winter were particularly high for those living in the southeastern states of Australia, such as Victoria and ACT, as marked by the darker colours, where nearly 1 in every 2 people were vitamin D deficient in winter, compared with only 16 and 13% respectively in summer, as can be seen in the first map. By comparison, vitamin D deficiency remained relatively low in winter for those in Queensland and in the Northern Territory. This could be reflecting the differences in the availability of UVB rays across the country, and also differences in the amount of time spent in the sun by people living in different parts of the country. The National Health Survey showed that use of vitamin D supplements was most common among those living in Tasmania and Victoria, and lowest in Queensland and the Northern Territory. Differences were also seen according to the remoteness of areas, with vitamin D deficiency being more common among those living in major cities compared with those living in inner regional, outer regional, and remote areas. Impact of vitamin D deficiency. Not everyone suffering from vitamin D deficiency will experience obvious signs. However, some may experience muscle aches, weakness, or low back pain. Bone weakness may also result and is often identified following a fracture and bone density scan. As has been explained already, we know that vitamin D deficiency increases the risk of falls in older people living in residential aged care facilities, as it contributes to muscle weakness, reduced balance, and weak bones. Although there is not sufficient evidence to demonstrate any direct relationship between vitamin D deficiency and disease, vitamin D deficiency has been found to be associated with a number of different medical conditions. These include cardiovascular disease, respiratory conditions including asthma, cystic fibrosis, and obstructive sleep apnea, gastrointestinal conditions including inflammatory bowel disease, chronic hepatitis, and pancreatitis, neurological conditions such as multiple sclerosis and depression, musculoskeletal conditions such as osteoarthritis and rheumatoid arthritis, metabolic conditions including diabetes and kidney disease, skin conditions such as eczema, a number of different cancers, and reduced cognitive or brain function. Who is at risk of vitamin D deficiency? Based on our understanding of how vitamin D is produced and absorbed, there are a number of population groups that have been identified as being at high risk of deficiency. As we age, our risk increases as our body's ability to synthesize vitamin D underneath the skin reduces. People who typically do not get enough sunlight exposure, such as those that are housebound, in residential aged care, those that cover their skin when outdoors, and people working in an enclosed environment are also at risk of deficiency. People with darker skin require longer periods of sun exposure to allow for the production of vitamin D and are therefore at higher risk of deficiency. Carrying excess body fat will result in the storage of more vitamin D, leaving less circulating around the body to absorb calcium and perform other important functions. Lastly, people that have difficulty absorbing vitamin D due to a medical condition such as Crohn's or celiac disease are also at risk of deficiency. Sources of vitamin D. As has been previously mentioned, the best source of vitamin D is from the sunlight's UVB rays. Access to UVB rays can be limited by the season and how far from the equator we live, and it should also be noted that UVB rays do not penetrate through glass, so sitting by a window inside will not provide exposure to UVB rays. Vitamin D is found in some foods, however only in small amounts, so this is usually not adequate as a sole source of vitamin D. All table margarines in Australia must be fortified with vitamin D. However, only selective milk products, including milk, yogurt, cheese, and soy milk, will have vitamin D added. Vitamin D is found naturally in eggs, mushrooms, and fatty fish, including salmon, herring, and mackerel. There are some mushrooms that are specifically exposed to UV light to stimulate the production of vitamin D, which are also available in Australia. For those at high risk of or have confirmed vitamin D deficiency, the most common treatment or preventative measure is vitamin D supplements. GPs are best able to advise individuals whether they would benefit from vitamin D supplements, and for people that are at high risk of deficiency, they may not need a blood test prior to starting a vitamin D supplement. Vitamin D supplements are available in a range of different formulations, including tablets, liquid drops, chewable gummies, and injections. The most common way of taking a vitamin D supplement is via a daily tablet. However, in some cases, people may have much larger dosages every few months. General recommendations for the Australian population to prevent vitamin D deficiency and osteoporosis is to seek safe and adequate sunlight exposure on most days. Specific recommendations for sunlight exposure will be covered on the next slide. If people are concerned that they may be at risk of or have low vitamin D, they are encouraged to discuss this with their GP, who can advise on whether supplements are required. They may also wish to discuss calcium supplements or see an accredited practicing dietitian to ensure that they are able to maximise their dietary intake of calcium. This diagram has been produced by Osteoporosis Australia to summarise the recommended amount of sun exposure required to produce sufficient vitamin D. Recommendations depend on the season, location, and skin type. As you can see, we need to spend more time in the sun if we have darker skin and the further south we live. We also need longer periods of sun exposure during the winter months, ideally in the middle of the day, compared to the summer months where sun exposure should be before 10 a.m. or after 2 p.m. for safe sun exposure. To ensure adequate vitamin D, we should be aiming to meet these recommendations on most days. The most recent review of the evidence for falls prevention interventions in residential aged care has concluded that vitamin D supplement use is the most effective method at reducing falls. This is in contrast to the evidence for falls prevention interventions for community-dwelling older adults, where exercise-based interventions has the strongest evidence. In 2009, the Australian Commission on Safety and Quality in Healthcare released guidelines for preventing falls in residential aged care facilities. Within these guidelines are a number of different recommended interventions, including that vitamin D and calcium supplementation should be recommended as a strategy to prevent falls in residents of residential aged care facilities. This has level 1 evidence, which is the highest level of evidence and means numerous studies have been conducted to show the benefits of vitamin D and calcium supplements on falls. Assessing residents for adequate sunlight exposure has been classed as a good practice point, as there is currently no evidence for this practice, though experts agree that it would be of benefit. Because we know that residents in aged care homes are at high risk of vitamin D deficiency and therefore also at risk of falls and have difficulty producing adequate vitamin D from exposure to sunlight, vitamin D supplements are recommended. Despite this evidence and recommended use of vitamin D supplements in residential aged care facilities, a recent study conducted by the University of Sydney looking at over 1,500 residents across 3 Australian states found that only 47% of residents were meeting this recommendation. This is certainly insufficient given we know that at least 1 out of every 2 residents will fall each year. Some of the possible reasons this may not be implemented is that people may not know much about the importance of vitamin D supplements. This emphasises the importance of this type of education and promotion of the use of best practice falls prevention guidelines. There may also be concerns regarding the prescription of multiple medications, when really the focus should be on optimising medication use to ensure only unnecessary medications are seized and not vitamin D. There may also be some concern around the cost to residents. However, this over-the-counter supplement can be sourced at very low costs. It may be thought that it is necessary to have a blood test to confirm whether a resident is vitamin D deficient, when in fact this is not always necessary in this high-risk population. Finally, there may be some concerns over whether supplements are safe. There are no known adverse events that have occurred as a result of vitamin D use, and your GP will be able to determine whether it is safe for you to start taking a vitamin D supplement. Encouraging residents and their families to discuss any of these concerns with their GP will allow them to understand the value of taking vitamin D supplements and why it is recommended for all residents for falls prevention. This table provides a summary of vitamin D supplementation guidelines. Although we have discussed that it is not always necessary to perform a blood test before prescribing a vitamin D supplement, residents that already have confirmed vitamin D deficiency require much higher initial doses to replace their stores, so GPs may request blood tests for those residents at very high risk of deficiency. The recommended dose for people at risk of deficiency, which includes all residents in aged care facilities, is between 1,000 to 2,000 international units per day. This is also suitable for mild vitamin D deficiency. Moderate and severe vitamin D deficiency, however, requires between 3,000 to 5,000 international units per day for 6 to 12 weeks before dropping back to a maintenance dose of between 1,000 and 2,000 international units. GPs can prescribe the most suitable formulation for their patients, be that vitamin D capsules, vitamin D liquid drops, or vitamin D injections. If a resident is prescribed large doses of vitamin D, their GP will usually order another blood test in 2 to 3 months' time to monitor vitamin D levels. It is also important to consider calcium in relation to vitamin D and falls in residential aged care facilities. We know that vitamin D increases the absorption of calcium for strong bones. However, it is important that adequate calcium is consumed for this to occur. Although calcium supplements are recommended for residents in aged care facilities, it is encouraged that this only be considered if residents are not consuming adequate calcium from food. This is because there is some evidence to suggest that high doses of calcium supplements is associated with cardiovascular or heart events, and we know that our bodies absorb calcium from food better than from calcium supplements. As you can see in the orange table, as we age, our calcium requirements increase and are particularly high for women to ensure our bone density is preserved. The green diagram explains how much of calcium-containing foods is equal to 1 serve. For example, for a 70-year-old woman to reach 4 serves of calcium each day, she could have a cup of milk on her morning cereal, a yoghurt for morning tea, cheese in her quiche for lunch, and then another cup of milk at supper as a hot chocolate. It is difficult to consume enough calcium if dairy foods are not part of a resident's everyday diet, as other foods only contain small amounts of calcium. An accredited practicing dietitian can advise on alternative options for individual residents, and a GP may consider calcium supplements in this instance. So to summarise what has been covered in this webinar, vitamin D is important for muscular strength and the absorption of calcium for strong bones to reduce falls and fractures. All residents in aged care homes are at high risk of vitamin D deficiency. To reduce falls and injury as a result of a fall, it is recommended that all residents be considered for vitamin D supplements. And it is also important to ensure adequate calcium intake, preferably from food, otherwise also from supplements. That concludes this presentation. Thank you for listening. We hope that you found this education informative and useful for your practice. Please complete the post-education questionnaire so that we can understand how useful you found this information by clicking on the link provided.